Good afternoon and welcome to a session dedicated to demonstrating the operational value of preventive medicine in the military and a model for civilian health. I'm Donna Grande, CEO of the American College of Preventive Medicine, a professional medical society representing nearly 2,000 physicians dedicated to the practice of preventive medicine. It's my honor to not only introduce our moderator, but to thank our service members and esteemed panelists who preserve, protect, and defend our nation's health. Nearly 1 in 10 ACPM members work in the military or in Veterans Health Services, and for that, I'm immensely grateful for their service. Now, let me introduce our moderator for today, Dr. Mirza Rahman. He currently serves as the president of the American College of Preventive Medicine and is a co-founder and president of the Guyanese Diaspora Charity. Dr. Rahman also serves as an adjunct associate professor of epidemiology at the Mailman School of Public Health at Columbia University. And he was recently appointed as an adjunct associate professor at the School of Medicine within the College of Medical Sciences at the University of Guyana in South America. So Dr. Rahman, take it away.
Thank you, Donna, and welcome everybody. I want to say also thanks to all of the military members who are part of ACPM and who work, as Donna said, protect and defend this country. We have an esteemed panel this afternoon, and with us is the retired Rear Admiral, Dr. Boris Lushniak, who's going to be introducing us to preventive medicine. He currently serves as the Dean at the University of Maryland School of Public Health and is a former Surgeon General, acting Surgeon General from 2013 to 2014. And in addition, if he didn't have enough work to do, Dr. Lushniak serves on the Board of Regents for the College of Preventive Medicine. Dr. Lushniak?
Yes, thank you so much, Dr. Raymond. And as stated, my name is Boris Lushniak. I had the pleasure of actually serving for 27 years in uniform in the United States Public Health Service Commission Corps, 16 years at CDC, 6 years at the Food and Drug Administration, where I ran the Office of Counterterrorism and Emerging Threats, and then 5 years in the Office of the Surgeon General as U.S. Deputy Surgeon General for 5 years, and as stated, about 1.5 years as the acting U.S. Surgeon General. The reason I emphasize all that is that, you know, in that litany, you talk about even in government service, CDC, FDA, Surgeon General's office. In essence, that's what preventive medicine docs do, right? They take on obligations, they take on the challenges, they take on the service to be able ultimately to prevent disease. And in my first few minutes, I'm really going to emphasize not necessarily military preventive medicine. We'll have others talking about that shortly, but just giving you a primer on what preventive medicine is all about. Next slide, please. So preventive medicine, you know, oftentimes people think of it as just a sideline of things, but no, preventive medicine is actually a specialty within the field of medicine. So much like you would have a surgeon, a pediatrician, a family physician, a neurosurgeon, preventive medicine is in essence an important component of the house of medicine. We view it as an essential medical specialty because it's all focused on what? It's focused on preventing disease. You know, in medicine, we spend a lot of time on treating disease, right? But here, the whole aspect is how do we get ahead of the curve? Preventing disease, preventing disability, preventing death by promoting health and well-being among patients. So there's the individual interactions, but also about our communities and about populations. We're dedicated to improving systems for all populations, and we're an indispensable resource in building towards health equity. We are accredited by something called ACGME, which is the Accreditation Council for Graduate Medical Education, and we are one of the 24 specialties recognized by the American Board of Medical Specialties. Next slide. So when we talk about the training in preventive medicine, we have to sort of bring it back a little bit and talk about what are the specialty areas that are part of the American Board of Preventive Medicine. Today, we'll mostly emphasize the aspects shown here on the left side part of the slide, which are accredited residencies. Part of the American Board of Preventive Medicine includes aerospace medicine. That's in the family of preventive medicine. It includes occupational medicine, an area that I was actually trained in, which looks at the workplace and the ability to not only diagnose and treat diseases that are work-related, but prevent those diseases, and then public health and general preventive medicine. In addition, there are fellowships. When we look at the opportunities that preventive medicine physicians have, they can actually get further trained in the area of addiction medicine, in clinical informatics, in healthcare administration, leadership and management, in medical toxicology, as well as undersea hyperbaric medicine. So you can see that even in that one term, preventive medicine, I, in essence, open up a whole lot of opportunities for the medical students who are interested in this area, the residents that are trained, but ultimately the physicians who serve in all these areas. Next slide. So when we talk about the specific areas, public health and general preventive medicine that focuses on preventing disease, promoting health and health equity, as I mentioned, in individuals, communities, and populations. When we talk about occupational environmental medicine, that's focused on work-related injuries and illnesses. And then aerospace medicine focuses on the clinical care, research, and operational support, health and safety of crew members, passengers of air and space vehicles, and support personnel. Next slide. And we talk about career pathways, specifically in the field of preventive medicine. I like the right side of the upper corner of this slide that talks about where do preventive medicine physicians work. And in essence, they kind of work in all areas where there is that aspect or the ability to focus on prevention. This includes within hospital settings. This includes within the government, for example, at places where the Public Health Service has served or where officers in the Department of Defense serve, places like CDC, NIH, FDA have preventive medicine docs within them. The military is mentioned here, within laboratories, within business, and certainly within academia. The competencies and careers on the lower part of this slide talk about what are we trained in? And in essence, there's aspects on the left side begins with epidemiology, looks at infectious diseases, environmental health, behavioral and mental health, biostatistics, clinical preventive medicine, and lifestyle medicine, and then health systems management. So embedded in that and in small print are various really specific areas of where we can focus on from a career path. But really the competencies that exist there are really focused with this idea of, don't forget, prevention, right? Preventing disease, injury, disability, and premature death. Next slide. So our pathways, just so you can begin to understand what does it take to become a preventive medicine doc. Well, the pathway one is medical school, right? A person completes medical school, goes into a transitional year or preliminary year of a residency program, a general residency program, or rotating, and then enters a preventive medicine residency for a total of 3 years. This is now the most commonly pursued pathway in this specialty arena. The second pathway, which allows with the idea that people are trained in other fields and somehow along the pathway find preventive medicine, that's medical school, going into clinical residency, for example, family medicine, internal medicine, pediatrics, then go into preventive medicine, and that's a 5 years total pathway. And then the final pathway is medical school and finding a combined clinical residency and preventive medicine residency. So in essence, you get a twofer there. You're trained as a family physician, perhaps, and you're also in a preventive medicine pathway. That's 4 to 5 years total. The common theme here is that this is additional training beyond medical school. So medical school is 4 years. Now we're talking anywhere from 7 to 12 years or 7 to 8 years total for these types of pathways of education. So it isn't that preventive medicine docs take any short circuit or shorter approach to their educational pathway. They just emphasize the idea of prevention in their training. Next slide. This gives an example of where the residency programs are located. We have the public health and general preventive medicine programs, 42 of them delineated in red. Occupational and environmental medicine programs, 23 of those across the nation, delineated in green. And then aerospace medicine, 5 programs across the country delineated here in blue. So certainly to the staffers who are present here today, you can sort of find your jurisdiction. You can see that there are limited programs across the nation. That's one of the major drawback is the funding for preventive medicine residency programs. That's been a problem arena throughout the nation. We aren't producing enough preventive medicine docs is the bottom line. Next slide. And where do they practice? This again is a chart or a map of the nation showing where the preventive public health and general preventive medicine, green, aerospace medicine, black, and occupational environmental medicine docs are focused. And you can see in urban areas where there may be big bases, for example, in the military, and certainly the urban areas throughout the United States. Next slide. And this is again where the diplomats practice, the diplomats of the American Board of Preventive Medicine, and once again looking at all the subspecialty diplomats, not just by the specific training mechanisms. And you can see urban areas in general. So we really do have a dearth in rural areas of preventive medicine specialists. Next slide. So I'm going to pass the microphone on to a good friend of mine who's a professor and chair, or maybe I'll pass it back to Dr. Raymond, who's going to introduce Jamie Mancuso.
Thank you, Dr. Lushniak. I appreciate that. It's a great, succinct introduction to preventive medicine, and that's helpful as we talk about military preventive medicine as a model for civilian health. As you indicated, Dr. James Mancuso, retired colonel, will be talking to us about military preventive medicine as a specialty. And Dr. Mancuso is the chair of the Uniformed Services University of the Health Sciences Department of Preventive Medicine and Biostatistics. Dr. Mancuso?
Thanks so much. Yes, I'm pleased to be talking to you today here about the specialty of preventive medicine in the U.S. military and the specific way that we practice that through force health protection. Next slide. So this is the formal definition of military preventive medicine and how it's practiced in the military. So it's very similar to the way preventive medicine is applied in the civilian world. You'll see in that definition lots of things about prevention and control of communicable diseases, injuries, occupational environmental exposures, etc., and threats to health. And again, that's standard public health, right? What makes us unique is our focus on that next part, which is readiness of our personnel. So next slide. So how do we do that? We do that through what we call force health protection. That's how we operationalize preventive medicine in the military. And you see here a very similar definition: promoting, improving, conserving health and well-being, enabling healthy and fit for forces. Again, emphasizing that need for not only health, but also readiness of our soldiers and sailors, airmen, and Marines. And the way that we do that is protecting the force from those health hazards. Next slide. So how do we do that? We operationalize that through that. The first step is assessment, and we assess different types of health threats. This is one of the major categorization of those health threats. You'll see things like endemic, communicable disease threats is the first block there. Maybe you can't read that. But you know, the typical things: malaria, diarrheal disease, other things, respiratory diseases, COVID, pandemics. And then the next category is occupational environmental health threats, things that you've probably heard about in the news: burn pits, depleted uranium, Agent Orange. And then further down on the list, things like physiologic and psychological responses. Again, you've heard about things like PTSD, TBI, and suicide as not just health threats that are common to all of society, but also have unique health threats to the military services due to those exposures and other deployments and other things. Next slide. We also need to consider unique military exposures in addition to just the outcomes themselves. So things like occupations, like pilots who have very specific risks related to flight, special forces which have very specific exposures due to their deployments and other things that they're doing which are very unique. And then we have other occupations like healthcare workers, prison detainee operations, which will have specific exposures to those populations, which are somewhat similar to civilian populations. And then our environments also tend to be somewhat unique. Recruit populations, you may or may not know this, but those also recruits also encounter unique health threats such as adenovirus, skin and soft tissue infections. Field settings, in addition to those during deployments, we have field settings in CONUS or the contiguous United States or other training settings, such as the Jungle Warfare Training School in Okinawa, which our Marines and other service members are at risk for things like leptospirosis. Ships also have a unique environment, healthcare settings, and others. Next slide. So in order to counter those health threats and protect our forces, we employ countermeasures. So mitigation, things that we do to mitigate and communicate those threats to not just our service members, but also their commanders, their leaders, because we find that just like in the civilian world where nothing happens without leadership, we provide recommendations, and those recommendations have to be executed by the leadership. So we, just like in the civilian world where we can't get good results from our public health measures without political leadership, we also can't get good, effective preventive measures without command buy-in and command enforcement in the military. Next slide. So this is one example of how that's operationalized. One good example of a health threat is malaria. So we've had outbreaks of malaria in Liberia and other settings. Next, if you could advance it one. We've had fatalities. This is an example of a fatality from malaria in Liberia, even a few years after we had that outbreak in Liberia. So next slide, advance it one more. And then even beyond that, we've had other recent examples of malaria. So we know that this is a threat in certain places. Next slide. So we apply countermeasures through things that you may have encountered in your own travels, using, covering up your skin, what we call it the DoD repellent system, but also using insect repellent, using treated clothing, using bed nets, being prescribed chemoprophylaxis, antimalarial medication. So things that we would prescribe and offer to the individual service member, just like you would any patient who is going to a malarious area. We also look at higher level things like installation, healthcare facility, system, such as malaria testing, treatment capabilities at healthcare facilities, and then system-wide surveillance for things like malaria and fever, environmental control of the vectors, the mosquito that transmits malaria, and then again, as I mentioned before, command enforcement. Next slide. So that's just one example of how force health protection and public health preventive medicine is operationalized in the military. There are other components of force health protection in the military, but preventive medicine is the most important. You see, again, that's the bulk of our programs and functions within the military are preventive medicine, but we also have veterinary services, which are allied, that we use for One Health, food inspections, laboratory, combat stress control, vision, and dentistry. Next slide. This is a list of the preventive medicine functions. And again, it's not enough to have the desire to prevent disease. You also need to have ways to operationalize that. And we have a number of different regulations, a number of different programs, which we operationalize our preventive medicine activities. So disease prevention and control. We have environmental health services, occupational health services, public health nursing, and then risk communication specialists. Next slide. Again, those functions are operationalized in programs, and most of our installations and deployed activities will have most or all of these programs: disease prevention and control, environmental health, occupational health, and industrial hygiene, nursing, infection control. So, some more than others, but depending on the activities undergoing at those locations. Next slide. Like our civilian counterparts, we are also charged with combating public health emergencies. And so again, very active during the COVID times, just like our civilian counterparts. And again, for us, our military commanders are largely the equivalent of the elected officials that our civilian counterparts deal with. But we have formally stated and assigned duties to be public health emergency officers. We have required training. And again, we have implementing guidance and a formalized role as public health emergency officers throughout the DoD. Next slide. And even our primary care and unit surgeons, those folks that are providing the primary care at the unit level, also have assigned preventive medicine responsibilities. They're not necessarily preventive medicine experts, but they can reach out to higher levels of preventive medicine care so that to get consultation on those. So you see there the health of the command, assessing health threats, mitigating and communicating those. The next row there is force health protection, ensuring that environmental control, field sanitation takes place, and analyzing disease and non-battle injury data and doing surveillance for preventive medicine threats in the field. Next slide. I just wanted to show some of the useful references just to show the robust amount of guidance that we have for our service members and the operationalization of these programs throughout the DoD. Next slide.
I think that'll we'll transition. So thank you, Dr. Mancuso. I think it's great that we get a sense of what military preventive medicine is as a specialty. And obviously, you've got to train those preventive medicine physicians. And so here to tell us a little bit about that is Colonel Amy Costello. She is the Program Director in Public Health and General Preventive Medicine Residency at the Uniformed Services University of the Health Sciences. Welcome, Dr. Costello.
Thank you, Dr. Ruckman. Thank you for the introduction and for giving me the chance to talk a little bit about how we provide graduate education in preventive medicine within the Department of Defense, because it is a subject near to my heart. So next slide. All right, so I'm just going to talk about the basics today, introduce our preventive medicine residencies, talk a little bit about what we teach our residents to do. And it's the same thing as our civilian counterparts teach. We just have the additional need to prepare our residents to be ready to do whatever it is the military needs them to do when they leave our program. So next slide. Of course, these are my personal views. They do not necessarily reflect the views of the Department of Defense. And next slide. All right, so as Dr. Lushniak said, there are 3 specialties within the field of preventive medicine, plus many subspecialties. Since I work in public health and general preventive medicine, that's kind of where I'm going to focus today. So the Department of Defense has 2 public health and general preventive medicine programs. One here in Bethesda, Maryland on the Walter Reed campus, and then another Army-specific program over on the West Coast in Washington near Seattle. Our program is tri-service. We take Air Force, Navy, and Army residents, physicians, and train them to go out in the world and do preventive medicine. We've been fully accredited for over 30 years now. Our counterparts out at Fort Lewis, they are a little bit smaller. They're Army specific. They've been around a little bit longer than us. And I just realized that I guess they're having their 40-year anniversary this year. And then not to be left out, the Army had a second program here on the East Coast for a long time that was very productive, turned out a lot of residents. They, a few years ago, closed that program and divided their trainees between us in Bethesda and our counterparts at Madigan. All right, next slide. Okay, so the military services use our graduates in a variety of ways, and we have to prepare them for a broad scope of practice. So force health protection, as Dr. Mancuso talked about, similar in many ways to the work that you do at a county or state health department, just focused on a different population. Within that realm, we have our residents have a variety of areas and interests. And so we have, on the one hand, the global health people, and they want to be in the Amazonian rainforest studying emerging infectious diseases, or they want to be in Eastern Europe trying to control tuberculosis. And on the other end of the spectrum, we have our informaticists who want to be indoors and who are happiest when they're talking to computers. And so we have to develop a program that can provide all of them with the knowledge and skills that they need to go out and make a difference in the world. When they leave, we need them to be teachers. We need them to educate the people that come after them, as well as the public health workforce. The military is a highly mobile population, and we need them to be ready at every location to make sure that everybody is full up and able to complete the mission that they're assigned. And then finally, as Dr. Mancuso alluded to, we need them to be leaders when they graduate. So they're leaders in the military public health sector, but they're also eventually end up in the civilian public health sector, like Dr. Lishniak and Dr. Mancuso now, and leading in those capacities. And so we need them to be able not only to lead the people that work for them, but also to be able to work with their military and civilian and political leadership to communicate effectively about sort of all the critical emerging public health threats that we face. All right, so next slide. So how do we get them ready for that? Well, we have 2 years, 2 years broken down into 3 components. So academics, obviously, we have them study the nuts and bolts of public health, earn either a master's of public health or a master's of public health in tropical medicine. We need them to be competent clinicians. So they have 4 clinical months, and they come from a variety of backgrounds, like a really broad spectrum of backgrounds. And so we try to balance everybody's clinical training to make sure that they all leave on roughly a similar footing. So there's the bread and butter military preventive medicine and county health department, but we also need them to be very capable travel medicine physicians to support the DoD around the world. We need them to have some familiarity, at least with flight medicine. And then as Dr. Mancuso alluded to, trainee health and our special warfare training pipelines have some really unique aspects of care, and they need to be ready to keep those people safe because it's a highly volatile and more dangerous environment than you'd even think, even knowing that it's special warfare. And then finally, they do roughly 6 public health rotations. So they do an operational rotation with their parent service. They do a policy rotation with their service surgeon general public health office. We have them spend 8 weeks at the county health department. For us, it's either Montgomery County or Fairfax County, and the county health officers there are just tremendously capable educators and generous in teaching our residents. We have them spend a month at the DoD Medical Surveillance Agency. And then if you're familiar with the USPSTF and ARC task force that put out the public health recommendations or the preventive medicine recommendations for the US as a whole, they spend some time there. And then they can choose an elective rotation as well. So next slide. All right, and so obviously I think it's probably pretty clear that the mission of preventive medicine physicians is critical to the DoD, but it's interesting, we make up a pretty substantive contribution to the civilian preventive medicine community as well. For context, military medical student graduates make up less than 5% of total physician graduates every year in the US. But if you look at the numbers for the preventive medicine specialties, we're considerably higher. So rough estimate, but you could probably guess that military preventive medicine physicians make up about 10 to 15% of preventive medicine docs in the US. The aerospace medicine physicians are much higher, make up a much broader component of them. And then the ACPM physicians over the years, probably we make up about 10% of occupational medicine physicians, although recently, I think some of the docs did a study, and it looks like DoD currently is funding about 20% of US occupational medicine training slots. And so that's important. One of the biggest challenges, I think, in this specialty is funding, right? So we're preventive. We're not billing for cardiac caths. We're not billing for hip replacements. DoD invests heavily in preventive medicine because keeping people healthy preserves the mission, right? So there's a lot of jobs in the civilian world that you can do if you're not in perfect health, and you can replace people quickly if they leave. In the military, our jobs are physically demanding, our pipeline is long, and it makes much more sense to keep people healthy than to have to repair them or replace them. And so mission first is the primary reason that DoD funds so thoroughly the preventive medicine mission. But it turns out our preventive care also reduces the healthcare expenditures. And so you're probably familiar with the fact that the healthcare budget is a large part of DoD, and we are actually fairly effective in at least flattening that curve a little bit. And then the unintended benefit, of course, is our contribution to the overall US preventive medicine infrastructure. All right, so next slide. All right, so how do we know if we're doing a good job? Obviously, we look at our immediate tangible metrics, our board passage rate. So our residents all take board exams to become certified in their specialty, and our rates are high. We survey employers. So for 5 years after a resident graduates, we send surveys to their employers to find out if they have the skills that they need to do the jobs that their bosses need them to do. And we send surveys to our graduates as well for 5 years to find out if we taught them what they needed to do and if there are other things that we should be teaching to the classes coming up behind them. And then our less tangible results, our graduates are in high demand when they leave here from the services. And every year the military services ask me to take more trainees than I'm accredited for, which I assume is a tribute to the quality of the trainees they're getting from us. And even during residency, our residents are highly sought after at the agencies that they rotate at because the work they do is useful. And so we look at our tangible outcomes, but we also look at our contributions and our program's reputation within the services. And we don't rest on our laurels, but we are very pleased with our graduates' performance. And we recognize that a lot of our success is due, as I mentioned earlier, to our sustained and dedicated funding from the Department of Defense, because they appreciate our value and they don't take chances with causing damage to the pipeline. So we are able to do long-range planning for our curriculum and our academics, and we can provide consistent, high-quality education to our residents. And that was all I had. So thank you.
Thank you, Colonel Costello. That's a great overview of training military preventive medicine physicians. So if we train them, what do they go out and do in practice? You have great pictures, but here we're going to hear a little bit about war and peace. So military preventive medicine in practice. I'm going to introduce Colonel Retired Michael Bromwich. He's an acting senior medical director at Tariana Chiefs Conference. Dr. Bromwich?
Thank you very much, Dr. Rahman. And unlike the book War and Peace, this will be quite a bit shorter. But I did want to highlight some of the career opportunities that I had as a result of my training in military preventive medicine and how that has translated into a career on the civilian side as well. Next slide. Dr. Mancuso mentioned earlier about battalion and brigade surgeons needing to have some competency in preventive medicine. And I was fortunate in that the Army allowed me to do a preventive medicine residency after I was already an established internal medicine physician. And so I was able to go to Madigan Army Medical Center and the University of Washington to get my MPH and to become a preventive medicine doc. And my first gig right out of residency was to become a division surgeon. So I had 3 brigade surgeons working underneath of me and countless battalion surgeons. But that training in preventive medicine really prepared me very well for challenges on the battlefield. Everything from things that you've heard about before, like preventing infectious diseases, especially leishmaniasis, which had been taking our soldiers off the battlefield to be sent back to Walter Reed Army Medical Center to be treated with a very toxic drug, as well as malaria chemoprophylaxis, vaccine adherence, and also thinking about trauma protection from ballistic injuries through protective items. Hearing protection, ballistic eyewear, all of those things prevented soldiers from acquiring more egregious injuries and kept them on the battlefield. Iraq, as you know, is very hot. The average daily temperature between April and August was 104 degrees Fahrenheit, with highs up to 126 degrees Fahrenheit. Heat injuries were obviously a major concern. And so we worked with our commanders. This has to do with risk communication that we've heard about before. being able to communicate to commanders about keeping their soldiers healthy and preventing them from becoming heat injuries. And then we also engaged in civil military operations, what our general called the non-kinetic actions, in order to build trust with the Iraqi population. So building health capacity and not necessarily just rolling up and starting a clinic in a village, and really talking to commanders about how valuable that experience is. And also being able to identify and measure military environmental exposures, which helped me later on when I worked for VA in an office called Health Outcomes Military Exposures, which we'll talk about later. Next slide. So in peacetime, we help protect and project America's interests. So we provide valuable training and expertise to military leaders and U.S. partners. And so I had the opportunity to be part of teams that represented the United States in a number of international settings, including training in pandemic influenza preparedness. Our old friend, highly pathogenic avian influenza H5N1 was a real concern back in 2005 and 2008 when I was doing this kind of training, as it is today. And we're seeing this rear its ugly head again as a potential next pandemic virus. We also were able to work with DoD stocks to provide excess U.S. influenza vaccine to our U.S. affiliated Pacific Island partners, and represented the United States at a number of military to military meetings, as you can see on the list, including to the People's Republic of China and a military to military exchange with the People's Liberation Army, where we were invited to talk in Beijing and Wuhan, and I actually was able to present on pandemic preparedness in Wuhan, of all things. And then also working to mitigate dengue fever outbreaks at another U.S. affiliated Pacific Island chain, Majuro, in the Marshall Islands. Next slide. Dr. Mancuso knows a lot about Operation Tomodachi, which was the aftermath in 2011 of the magnitude 9.0 Great Tohoku earthquake and tsunami, which triggered the Fukushima nuclear power plant meltdown. There are actually more U.S. military members in Japan than there are in Korea. A lot of people don't know that. And so there was a real concern about the spread of radiation among the population there. It was the first time in my career I had ever seen entire communities go into a panic. I was able then to also go to the Tohoku region to witness the tsunami inundation zone personally, work with the Japanese self-defense forces and recovery operations. And this is where the training and risk communication, we heard about training and risk communication. This was where it was put to real use, facing uncertain audiences, both uniformed and civilian, about what the radiation was going to do to them, to their pets, to their children. And so these became sort of valuable training lessons from my residency that I was able then to apply in real life. Next slide. In 2015, I put away my uniform and walked into the middle ground zero of the opioid epidemic in Charleston, West Virginia, and really became a voice for addressing the complex social issues around the opioid crisis, specifically adverse childhood experiences and the social determinants of health. Was invited to sit on a panel with President Obama when he came to Charleston in 2015, and then moved on to another position with a federally qualified health center. In responding to the pandemic, I was asked to write an article for The Atlantic about rural response to the pandemic, and then moved on, had a career for a few years with VA, where I worked in, as I said before, health outcomes and military exposures, where we became technical experts advising congressional staffs on the components of the PACT Act, which was signed into law in August 2022 by President Biden, and currently working for tribal health organizations on health inequities for Alaska Natives. So at the end of the day, preventive medicine provided me with wonderful training and a huge skill set that I would have never had as an internal medicine physician. And so I really have felt that I've benefited greatly, and I think the nation would benefit greatly from more preventive medicine trained physicians, not only in the military, but also in civilian life as well. That concludes my presentation. Thank you.
Thank you so much. And if we can go to questions that have come in, let me start with this one. How has the overlap between military preventive medicine and civilian health impacted the way you practice medicine? And maybe also for each of you, if you've been on active and reserve duty, talking a little bit about how preventive medicine physicians can join both as active members of the military and or as reservists. In no particular order.
Well, I'll go ahead and volunteer, since I talked just recently about my work as a civilian relative to that in the military, in that I really feel very, very strongly that the training I received in the military in preventive medicine translated very well into a skill set that I was able to carry into civilian practice that involved working with many sticky issues, military environmental exposures among veterans, also with regard to the opioid crisis. So I think it translates very, very well. At least that's my opinion.
You know,
Thank you,
let
Dr.
me take a little slightly different perspective on that. You know, in terms of not necessarily directly answering the question, but looking at the overlap between what military medicine does regarding prevention and what we can learn from on the civilian sector. Colonel Costello had a great line. I wrote this down because she mentioned the fact that in the military model, keeping people healthy is the mission, right, with preventive medicine. And I think a key component, what everybody needs to hear is, in essence, that emphasis on keeping people healthy is what we need, not just in the military population, right? That deals with the warfighter, with the concept of defending our nation, but in essence, to be able to have that theoretical, to have that operational viewpoint, and to embrace it in the civilian population, where we also should emphasize the concept of what? Of keeping people healthy. Now, most will argue, and I'm a clinician trained in family medicine, in dermatology, as well as in occupational medicine. So this idea of treating the patient, treating sickness is what physicians do. But the reality of the situation is how much of our limited resources, right, is spent on this idea on treating preventable illness. And I think this idea of getting ahead of the curve of prevention, right? Just to throw out numbers in terms of what the impact on our nation is. Right now, we're talking about in 2022, $4.5 trillion is what we spend on healthcare. That's over nearly $13,500 a person. Now, is that really healthcare? No, it's really sick care. We're treating sick people for the majority of that, because less than 3% of that $4.5 trillion is devoted towards public health and prevention. And I think what we see in the military model is, because we're defending our nation, we have to throw all of this at prevention. In the civilian model, we can learn a lot from this overlap between the military model and what we should be doing in the civilian world.
Completely agree with what you said, Dr. Lushniak. I think it's something that we can learn to do, but to echo your earlier comments, preventive medicine residencies are severely underfunded. When we went into DC last week, the week before, going up to Congress to try to get an increase that hasn't come for years. And so this is something that is a challenge. And, you know, Dr. Casella, you don't have to worry about funding your residency, but you do have to worry about getting it expanded. But it's an entirely different function than what your colleagues, the challenges they face. But, you know, talk a little bit about how, if you can, how do you get folks who are maybe trained as preventive medicine docs interested in the military, because they get to practice an entirely different way, as Dr. Lushniak said. They get to focus on prevention, whereas in much of their job, it may be a little bit of a sideline.
If I could just piggyback on something that
Sure.
Dr. Rahman just said, I think it's important to note that, like, I think it's okay for me to toot Dr. Costello's horn. I think in my humble opinion, again, I'm biased, but I think she runs the best preventive medicine residency in the program in the country. Again, I am a little bit biased, but and part of that is because we get great Americans, we get great leaders like Dr. Costello, we get great applicants that come through. But part of it is the recognition of the importance of preventive medicine to the health and well-being of our service members, those unique importance, not just on their health, but also on their readiness. And so that translates into programs, and that translates into resources and funding. And so I think one of the most important reasons why I think that we have that Dr. Costello runs the best preventive medicine residency in the country is because of the resources that the military applies to it. So again, I do want to sort of foot stomp that, and I think I've alluded to some of the reasons why I think there's a lot of overlap between the preventive medicine and in the military and civilian world. We have that unique focus on force health protection and readiness. We have unique exposures, and again, our leaders have recognized that and resourced us to counter those health threats. I also want to mention that we do have quite a lot of overlap with our civilian colleagues. We do a lot of the same things that they do, even though we do have those unique aspects of it. A lot of what we do is very similar. Public health emergency officers, doing surveillance, communicable disease, chronic disease control. And we do collaborate with our civilian colleagues. For example, I work down at the DC Health Department. I've volunteered there for about 10 years in communicable disease and STI and TB clinics over there. And I think there's a lot of things that we can learn from each other and benefit from that collaboration. We have I think there's some things that the civilian world can learn from us, and there's things that we can learn from the civilian world. Like they have different populations. We tend to have a very healthy population, young. We have these restrictive medical standards for people coming in, so we can benefit from collaborating and understanding that civilian health and public health perspective as well.
Terrific. Thank you, Dr. Mancuso. I know it's been a really good conversation so far. Before I turn it over to our CEO, Donna Grande, to ask a question, I'm thinking, Dr. Costello, it must be great to hear such wonderful praise from your boss. So congratulations. Donna?
Yeah, I continue to be in awe of the work that preventive medicine physicians do in mitigating disease and preventing premature death. And each of you have done such remarkable work in your careers. Dr. Mancuso, you and Dr. Costello both talked a lot about health leadership and providing leadership and the critical nature of leadership. What is the one thing from your point of view that our Congress could actually embark on that would demonstrate leadership by replicating what is done in the military for civilian life?
Well, I'm in the active duty military, so I will not advise Congress. We'll defer that question.
Yeah. So again, as you know, that Dr. Costello and I are both are federal employees, so we're speaking on behalf of ourselves and not representing ACPM or the federal government or anybody else in this. These are our opinions of our own, and again, we don't speak for anybody else. But I think I would just highlight what I mentioned before is I do think the quality of our programs, and again, it's not just the program that Dr. Costello runs. We also have a program, a great program at Madigan Army Medical Center, and all of our GME, graduate medical education platforms, are excellent in the military because they're resourced. And I think a colleague of mine, when I first came into preventive medicine, said, "Vision without resources is hallucination." And so I think that rings true to me every time I hear about difficulties with getting things done. It really comes down to resourcing and valuing things by putting programs in place and attaching resources to those programs.
And I would like to say, speaking for myself, the ACPM gives us program directors through the GME subcommittee, a tremendous opportunity to talk to each other and network. And I will say that many of the problems that I have are very similar to the problems that my civilian counterparts have. in leading their civilian programs. But I am grateful at the end of every meeting that I don't have the financial constraints that they do. They spend an awful lot of time trying to figure out how they're going to get money to support their residents. And I am very grateful to be able to teach in an environment where I can focus on, sort of developing the best curricular resources that I can, and not how to pay for my poor residents' salaries.
And I think that's one of the biggest challenges, as Dr. Rahman mentioned, whenever we go on Capitol Hill and advocate for funding for residency programs through the Health Resources and Services Administration's line item, we are constantly challenged with demonstrating the value and the return on the investment of this type of investment in building the pipeline for preventive medicine physicians and the role that each of you serve in the military, and how much value you feel and emulate in the work that you do because of the investment through the Department of Defense. We certainly had investments from Health and Human Services and the other side of perhaps the other side of the branches of government. We might be able to have even more preventive medicine physicians trained to address civilian life in the way that Dr. Lushniak mentioned as well. If we could have a society that really valued health and good health outcomes, just think about how further along we would be in our country.
Great. Thanks, Donna. Maybe the last question as we're looking to wrap up. If you can talk a little bit about the value that you bring, and you've shared a little bit, Dr. Brumage, about what you have done in various aspects in practice, but maybe also if we can have Doctors Lushniak, Costello, and Mancuso talk about the value, whether it's, when you're deployed, when you're in civilian life, dealing with epidemics or outbreaks. Talk a little bit about that value, and then also to what it means to develop a new generation of leaders in this field of preventive medicine.
If you like, I can give some tangible examples. If you have any familiarity with county health departments, you know that they are not, they do their absolute best with every penny that comes their way. And so some of the projects that my residents have done recently, just working there, and I will say the Montgomery County Health Officer does a tremendous job utilizing them, but she wanted to start a mobile health clinic to go out to sort of the more remote and less resourced areas of our county. And so our residents have worked with that from the beginning in sequence. They've put together the SOPs for a mobile truck. What does it need to have? Everything that you need to know about that, how resourcing it, staffing it, maintaining it, how to start a mobile immunization clinic, how to start a mobile cancer screening clinic. So our residents have put that together. Going back a couple years during COVID, two of our residents developed our county's first COVID surveillance system, because you guys remember the beginning of COVID, it was crazy. And nobody had the resources to do what they needed to do. And they developed the system for the county, and then they worked with the state to sort of build it into the state surveillance system. And we're short on time, so I'll stop there and turn it over to someone else.
Anybody else want to chime in?
Well, I think I'll just add, again, during COVID, I think people really recognize the value of good public health assessment, mitigation, and communication skills. And so I think that's really brought the importance of public health expertise and leadership to the forefront. But I think, like the civilian world, we have our military commanders. Many of them are very aware of public health and preventive medicine and forced health protection, but some are not. And so I just think about my deployment to Pakistan, where I had a commander who was not really that concerned about preventive medicine issues. And so, just really trying to convince him to let us do the things that we needed to do to keep our forces there healthy, as well as, we were there this was after the earthquake in 2005, 2006. And by actually doing some of the things, participating in measles outbreaks, diagnosing, doing vaccination, cholera outbreaks, really looking at water and sanitation, diagnosing cholera, the things that we brought to the table by the end of that deployment, this commander, he got it at that. And the proof is in the pudding. He saw us in action. He saw what we could bring to him and expand his capabilities. So I think, really just getting out there and engaging with, whether it's political leadership or command leadership, and engaging with them and showing the value every day and engaging. That's where I see us really making our presence felt.
Terrific. Thank you, Dr. Mancuso. Drs. Lushniak or Brumage?
Yeah, I'm just going to finish up with this sort of, when you talk about value, the reality is it really sort of puts into the idea, or the idea is there about what preventive medicine is trained to do. And in essence, I'll sort of come up very stark circumstances. You don't expect a preventive medicine doc to do neurosurgery, right? That's not what we're trained to do. And there's no value in it. It'll only bring harm. But the reality is, in the world that exists right now, and specifically the civilian world, many docs are put into the role of doing preventive medicine without any training. And if we're really looking at value, why are we allowing the world to exist that just because we have an MD degree that somehow we can do all these public health jobs that may be out there, health department jobs, etc. So my sense is the value here is train up people to do prevention, put an emphasis on prevention. The return on your dollar becomes quite evident because ultimately, depending on which statistics you believe in, 50 to 75% of all illness out there is preventable. So the person that we're treating with diabetes, right now with insulin, with oral hypoglycemics, if we had in fact tackled prevention 20 years ago, 5 years ago, 10 years ago, weight loss, exercise, we're eating the right foods. If we had taken that approach, we would have saved not only that person suffering with the disease, but the resources that go into supporting that person. That's an example of value of prevention medicine. Let preventive medicine docs be trained, finance their training to a highest level, get enough of them out there, and we can in fact change the world and have value-driven examples of how we bring healthcare expenditures, or rather sick care expenditures, down in this country.
Terrific. Well, this has been a wonderful hour. Thank you all for joining us on this military preventive medicine as a civilian model for civilian health. Thanks to the American College of Preventive Medicine for putting it together, Donna Grande and Noah Eisenstein. I also want to thank our four panelists introducing preventive medicine: Dr. Boris Lushniak, military preventive medicine as a specialty, Colonel James Mancuso, training military preventive medicine physicians, Colonel Amy Costello, and military preventive medicine in practice, we had Colonel Michael Brumage. On the slide, you'll see here an ancient quote before we had that, about 4,600 years ago, talking about, and not to disparage any physicians or specialties, but inferior doctors treat patients' disease, mediocre doctors treat the patient as a person, superior doctors treat the community as a whole. And that's what preventive medicine docs do. We look at communities and we work in population health to make the whole community healthier. For more information, you can certainly contact Donna Grande or Noah Eisenstein. And we also want to highlight to you that we do have something that you may be interested in. You see down in the corner in the blue box, Military Environmental Exposure Certification. The ACPM is proud to introduce this course in partnership with the Department of Veterans Affairs. And so for folks who are interested, please follow up and with the ACPM and take advantage of this opportunity. Again, thank you all for joining. Have a wonderful rest of your day.